Can you all hear us on Teams?
Yeah.
Okay, welcome then to the public board. As you can see, due to operational issues and the industrial action yesterday, we're keeping the board quite a short meeting compared to our normal board meetings. We're focusing this morning on assurance processes. So we'll start the meeting and we'll see how we get on. Any apologies, Company Secretary?
Yes, thanks, Mike. So we've got apologies from Chris Adcock, Bev Edgar, Jane McNicholas, and Phil Woodford. We've got Ray here on behalf of Bev, and we've got Helen on behalf of Chris, and Suzanne's also joining us today in respect of the operational side of things, including the IPR.
Okay, any declarations of interest from colleagues? Scott?
Sorry, Chair, just an apology and that I will have to dial off at 10 o'clock to chair the incident management team.
Yeah, thank you, Scott.
Thank you.
Okay, just double check, no declarations of interest declared. Okay, minutes of the Board of Directors held on the 30th of November. Morning to you. Somebody want to approve the minutes?
To approve,
Thank you, Adrian.
Mike, there's just one line of Sarah's raised with us.
Yeah, and which has been picked up. So corrected in the minutes. Yeah.
Any action sheets, matters arising?
The main one just to pick up, Mike, if you remember that we had a patient story at the last Board of Directors meeting that was written to thank the patient concerned. There was also the question of some financial recompense for the additional costs, and we've entered into a discussion with that particular. You all have been asked to write in if they wish to pursue that.
Thank you. Richard?
Thank you, Chair. Just on the action log, there's one for me at the end which related to a paper I brought last month. I had thought I was bringing something back in January, but it's down as February. I wonder if I was amazingly competent to be ready to bring you something back in January. We could fit it on the agenda then, given the topic.
We'll be having an agenda planning session, Rich, and if we can bring it forward to January, we'll be.
Thank you.
Okay, thank you. We'll take that as an action from the action sheet. Okay. No others? Thank you. Chair's report, standard update from me. I think you've all got it. I'm happy to answer any questions. Okay, I think the next item is probably of more interest to us. Chief Exec's report and an update on this week, please, Aaron.
Thanks, Chair. So in a break from my usual kind of cascade of national, regional and local, I am going to be a bit more specific on the local in the brief today. I'm going to start off, as I generally do, but very specific thank you today. The industrial action of yesterday, the impact on us as an organisation was significant. There was a lot of pressure and a lot of work that had to be done to manage that situation. But the temerity, tenacity, innovation, communication and leadership that I've seen in this organisation since Sunday, Monday in preparation and through yesterday and into today has been nothing short of exemplary. As a Chief Exec, and I've been at board level now for 15 or 16 years and I haven't seen a team come together like that before. I am going to signal out unusually Scott, Jane and Bridget in particular, who between them have been covering 24 hours and still coming in with limited sleep to service kind of roles during the day. And have led that incident management team again in an exemplary fashion. There's been some very, very impressive leadership on display. So I want to give thanks to the leadership team, also to those colleagues operationally and clinically have been working across both the urgent and elective pathways over the same period, who have been part of that leadership discussion, part of that innovation. I wish I could have bottled and filmed what I've seen in the incident room over the last few days, because if we can take some of that into our improvement work over the next phase, then this organisation is going to develop at a rate of knots. It's been great to see. And people grow and develop over the course even of a week, as you can see the confidence building in kind of decision making, what they're expected to do. We now are in a position where obviously the industrial action has ended from North West Ambulance Service, ambulance generally across the country. However, We are going to retain our incident management infrastructure right up until close of play on Friday. And I know throughout today and tomorrow, there are going to be various conversations, including with myself, about what does business as usual look like as we head into the Christmas period and the extended bank holiday. We generally have our 3 times a day bed and site meetings, which are well established. The incident management team infrastructure is different to that. So we'll just be having a conversation as a leadership team as to what arrangements we either really retain or we move back into business as usual. And I'll brief the board close of play tomorrow to let everyone know what the arrangements are. The board has received over previous months the winter plan, including what our expected plans are over this period. That is in place and being mobilised. And Scott and I met with Morecambe Bay kind of system leadership partners yesterday to think about what else ourselves or other partners could be doing that might help over this next period. I think some specific discussions with social care around residential care capacity, domiciliary care capacity, which will be progressing over the course of today. There is further strike action played out on the 28th, so next week. We will be using the same scale of preparation and infrastructure that we've deployed this week, so that will be in place for next week. And what I've said to the teams is, as a bit of a strategic action, there are some things that we've had to do over the course of the last few days to prepare, some of which are very clearly for Christmas and not for life. You know, there are things that we'll want to repair and put back, but there's also been some innovation in practice that I'd like us to consider what might be left behind and still retained as we develop. And I'll ask the executive team to consider that with the leadership teams on what we do with some of those improvements we've made over the last few days. There are other elements in my report, Chair, which speak to the development work we've done with the Provider Collaborative most recently, some of the engagement work we've been having with partners and with our teams, but I'm not going to concentrate on any further elements in my report, Chair, because a lot of them are replicated on the agenda.
You just give us a quick update, if you don't mind, Aaron, on patient care yesterday. You know, did we manage to see the patients, anything around urgent care, anything around criteria to reside yesterday?
Yeah.
Impact today and tomorrow?
So I'm really clear that there will have been incidences over the last few days and today, tomorrow, as we repair ourselves, where the standards of care wouldn't have been at the level we wanted under normal circumstances, either through extended waits or the experience of patients coming through our system. That needs to be clear. Any incidents or issues that we picked up will be managed through our own kind of normal incident raising processes and lessons learned. Where we need to look into that, we will. But what I saw was compassionate care and access to care that was established. No one didn't get the treatment they needed, despite having to wait a bit longer. We did stand down small amounts of some elective capacity, particularly at Barrow, to allow for some surge capacity open in our other surgical areas and for surgical staffing to support some of the wards where we had staff sickness. And we'll make sure that we bring a more fulsome report on reflections of the incident into into subsequent wards, Chair.
So for assurance purposes, we didn't have any incidents where patients were put in danger out with the context that you've just described. Urgent care managed to respond appropriately within the context, and elective by and large continue.
That's correct, Chair.
Okay. Questions to the Chief Exec? I think we're all very conscious of this week, and I think on behalf of the non-exec directors, I'd just like to express and echo what you've said, really, Aaron. So thank you to you and your team and everybody that's been involved, right, all areas, from estates, from bookings, from people dealing with their phones, all the way through to the clinical cold face. We recognise this week is a very difficult week, so thank you for that report. Okay, colleagues, you happy to move on? Okay, we've got the head governor update. I'll just check, is Lorraine here with us? It's to note. I'll present it on Lorraine's behalf then, if that's okay, as chair of the COG. You can see, you read it, it's to be noted, but I'm happy to answer any questions on it on behalf of the governors. Okay, thank you. And then we'll move on then to quality and safety item 1811. Care Quality Commission, Royal College of Surgeons improvement plans. Richard?
Thank you, Chair. So, excuse me, I'm going to take the report as read and be very brief. I wasn't in attendance at Quality Assurance Committee on Monday where the report was discussed more fully. I don't have anything to highlight unless there was anything that I missed on Monday, Hugh, that I probably should be aware of. I haven't caught up with my deputy yet. But the big takeaway here is that we're making good, robust progress with our actions, both must-dos and the should-dos, and I have no concerns otherwise. We did find in the last few weeks an anomaly in our AMAT system that seemed to record a cohort of actions in there. We weren't quite sure if they were a duplicate, and we're conducting an investigation to better understand what they are. They are described in this report. I don't have an update for you today, but if there is an update about the clarity as to what that anomaly was or is, I'll be sure to forward it on to the board members. Happy to take questions, Chair.
Before I pass questions to Richard, I'll just ask the Chair of the Quality to comment on Monday's meeting.
We we discussed it in detail, as you're right, Richard, and I think the word is reassured by the real progress that had taken place over the last month, both with clarifying issues and also with the progress that had taken place with closing off a number of items. We're also aware that a number of items were also due to be closed off almost like in the 2 days after we'd spoken, so on Monday. I mean, we were very aware of all that the Chief Executive of Justice described and the potential impact that may have on the issues that were due to be closed off at the end of this month. And we recognise that obviously some of those may well slip into the beginning of next year. But we will review things in January about that, regarding that. I don't know, sir, if you want to add anything to that.
Yeah, I think the only thing I asked for a bit more reassurance on, I suppose, at this stage was the actions that were due for closure in December and to understand whether there was slippage. And actually, we received a good amount of reassurance from your deputy, who actually outlined exactly where we're up to with each set of actions and when they should be signed off. So that did again provide an extra level of reassurance.
And just to ask you both, then, any assurance issues that you wish to bring to the board's attention?
No, there was nothing of that made.
Thank you. Any questions to Richard on his report? You've got the content. No, Richard. Thank you.
Thank you, Chair.
I'm sure we'll come back to it in more detail in our next board meeting. Niche external investigations assurance, item 1812.
Thank you, Chair.
Again.
So similar position, very confident going into the new year that we're making good progress. I keep saying every month that it's a very fluid situation. So by the time you've written it, and by the time you get to present it, the picture will have shifted. So when we wrote this, we had 45 recommendations that had reached level 3. I think by Monday there were 49, and who knows what's happened since then. So I'm confident that we are there or thereabouts in terms of the evidence that we need to send to Niche. The remaining supplementary evidence that we're in the process of sending is just churning through our normal governance arrangements, but we'll be with them before the 20th of January as promised to them. And I have no concerns that we won't get all 50 odd to Niche within that time frame. Thank you, Chair.
Once again, we discussed this in detail on Monday. I think really impressed by the amount of work that's gone on in collating all the information and getting it to Niche, and also I think to a degree assured by the notes review that had taken place and the initial feedback that we've received from that. The only clarification we received after the meeting, which we got a little bit during the meeting, but after the meeting, was to explain on the notes review, which is on page 64, I think, of the pack, where we've got that chart with greens and blues and whichever level because they were able to assess, they hoped they were going to be able to assess 19 of the key actions, recommendations through the notes review. There were several that they've noted that they were unable to assess, which means actually that they didn't find enough information within the selected notes that they looked at. But then there were also 3 where, and this is Nisha's table, it's not the trust's table, which was actually blank. So we actually queried, well, why are they actually blank? What does that mean? Does that mean we failed, or and again, in essence, it means they were unable to assess those, but they failed to note on the table that's what it meant. So that's just to clarify that chart. But other than that, I think the key date, we're all aware of that, is later this month when they come in and do the formal interviews with a number of us, and then they'll and I'm not quite sure the timescale, Richard, for them to look at all the evidence that you've given us and to get back to us. Are we aware of that at the moment?
We are. So the 16th to 17th of January is when they're planning to come and interview key individuals. The 5th of January is when we hope to have a board development session. I assume that date hasn't changed recently, where there'll be a briefing pack for all members ahead of those interviews. The Niche will then assess all the evidence, and I think the timescales mean that they should be back round about early February with some initial first draft report, and then the sequence will follow.
So we will obviously pick that up at the February Quality Committee, and then that'll feed into the board.
Yes, that's the plan.
Thanks, Chair. So it's just important. We've met a number of times as a leadership team over the last few weeks. Whilst we are dealing with really significant operational pressures and responding to the industrial action, there are a number of key programmes of work where we are trying as best we can to protect key colleagues to progress, so we don't lose momentum and we don't lose the evidence base that we're generating for assurance for these reviews. So obviously the Niche investigation and finalising phase 5 is one of them. The other is around the work we're doing on the CQC and RCS must and should do's in the way that Richard just articulated. And then the items that were required to satisfy the exit criteria, soft 4 reviews in Q4. So we've kind of compartmentalised as best we can the leadership team to enable that progress and that delivery to continue. That's not to say that there may not be slippage as we work through the Christmas period in particular, but we're sensitive to that and we'll bring any risks or escalations that needed through the assurance committees and board, and then we'll make reparations through kind of mitigations over the remaining period.
And just to circle the assurance, we've got the assurance from the subcommittee on Monday, but also I understand that Ned's a meeting with the urology team as well, having meetings with the clinicians, so we'll triangulate some of the data we found there as well. Karen?
Thank you, Chair. That was exactly what I was just going to highlight with regard to Appendix 2 on page 66, that we agreed to involve NEDS also in the drop-ins, particularly with that additional assurance and triangulation in mind. So
yeah, just we're taking it as an action point, Karen. The company secretary will alert the NEDS so that we can coordinate diaries. Great, thank you. Okay, any other questions on the Niche at the moment? We know where we're up to. No, thank you. Maternity safety update, Chief Nurse, item 182.
Oh, many thanks, Chair. So I'd just like to introduce, obviously, Heather's here as the Director of Midwifery, and I think just in terms of commentary for the purposes of public board, there are a number of papers that have come for maternity, and it's just to acknowledge the amount of work that's been demonstrated in terms of the improvement work in maternity, and particularly around the work towards CNST. So I'll hand over to the Director of Midwifery. Thank you.
Heather, just before you speak, just for guidance for us with the agenda, you've got items 182, 1 to 5. So how are you going to do this? You're going to deal with each item separately and then move us on to the next one?
Yes, I will, Chair, if that's okay.
That's fine. Welcome. You've got the floor, Heather.
Thank you, Chair. So the first paper is the maternity update paper. I will take the paper as read, but just for some highlights in terms of the report. Obviously, the report details the perinatal surveillance data that's in Appendix 1, but picking up the highlights from that data, I'd really like to point out to board around the training compliance for the MDT prompt training, the fact that we managed to achieve over 90% compliance, which was a really big ask, and I just really want to extend my thank you to all the multidisciplinary teams that really came out and got us across the line in terms of our CNST compliance. So just wanted to raise that. To note that our vision and strategy is currently in draft form. That was a CQC must do. So hopefully that will be published soon. We also achieved UNICEF BFI breastfeeding stage 1, which is a great achievement. The only other thing to point out from the maternity update report is also some staff raising issues of inclusion. So just to assure the board that we're currently doing a refresh of our cultural improvement plan. We've got support ongoing from the inclusion lead for the trust, Hannah. We've got a senior task and finish group set up, and we're reviewing our current cultural interventions. That's all I would like to draw the board's attention to for the maternity update paper.
Okay, Heather, I'll take questions from each of the paper in turn, if that's all right. Jill,
Yeah.
You've got your hand up, and welcome.
Thank you. I just wanted to ask Heather if the internal audit team are checking all our CNST data inputs, because that was one of the issues we had before as to whether we could be confident in what the data was, and I wondered if there's some internal checks.
We were looking at having internal auditors look at our either Ockenden or CNST processes. So I think in terms of assurance, bearing in mind where we've been previously with CNST, it's certainly something that we absolutely need to do to assure ourselves that it's as robust a process as it can be.
Thank you. The only other question I had was on Ockenden, and just for future reports, I wonder if we could give an indication of how we compare to other trusts, because when you read it, it feels like our trust, you feel like we're behind, but unless I missed it, it would be really good to have an indication of how we compare to other trusts.
Yeah, I don't know how we would actually do that, because it's not something that's readily available, but it's certainly something I can consider on how we could.
Would the national team who come and visit, would they not be able to give us an indication of that?
The regional team might be able to. It's something we can discuss with them when they come and do their visit.
Yeah. Thank you.
Well, could you pursue that, Heather, as an action point from the board, please?
Yes.
Before I bring you in, Karen, I'll just check with Bridget. Bridget, is your hand up because you're responding to Jill's question?
It is, thank you, Chair. So just to confirm that we've got a slot with MIAA for the purposes of maternity. And I will double check the quarter that's available on advised board. Thank you.
Thank you. I'll bring in Karen and then the Chief Exec. Karen?
Thank you, Chair. Thanks, Heather. I just really wanted to refer particularly to item 7, so page 71 and top of 72, and recognising all of the tremendous work that's going on here, and identifying those themes of learning from November. It's really a question about how we can then be assured that then that learning and that translation into smart actions, how can we be assured that that learning stays embedded?
I suppose in terms of learning longer. So if we look at some of the challenges in maternity services, if you look at what the local learning is, it's the same as the regional learning, it's the same as the national learning. So what I would be looking for is a decrease in terms of our instances of avoidable harm. So less babies transferred out for cooling, for example, where there's emissions or parts of care that aren't quite right. So using that data driven, being able to tell whether it's actually made a difference, because we can survey staff in terms of their learning, but it's actually what they deliver on the shop floor as well. So for me, it's about using the data to inform whether we've actually got measurable improvements at the end of it. And, you know, part of that was us getting our maternity data in a good position so it's accurate and we can use that then to see improvements and track them. And also our involvement in, you know, national work streams, etc., in terms of being able to show true improvement at the end and using data to be able to demonstrate that. So I think for me, it's about using our data and seeing if there's improvement, and if not, then changing what we're doing, going back, re-embedding, depending on what we find.
Thanks, Heather, and absolutely appreciate that. And I think my suggestion would be that if we can make that assurance around that learning embedded and making that difference, it would be really helpful to see that a little bit more explicitly referred to in the reports as we go forwards.
Yeah, I think when we get to that point, I think before we had to do a lot of data clearing and get that in a good position for us to be able to measure it.
Yeah,
thank you.
Absolutely acknowledge that, and it's great that we're at that point now to start to reflect that that learning. Thank you.
Thanks.
Karen, I'll just check, Sarah.
Thank you. We discussed this at Quality Committee on Monday. I think what we can see in the charts is that we've got some areas which are flagging as special cause variation. So, for example, number of women unsuccessfully induced, and also 3rd and 4th degree tears. And Heather, I just wondered if you could just update us on what we discussed in terms of what how that's being looked into and when we can expect to see an update on that.
Yeah, so some of the items we are doing thematic reviews on, just to note, we are talking small numbers, so sometimes it takes a bit of time for us to get data there's enough of it for it to be meaningful. And just because we do a thematic review doesn't necessarily mean that there's issues within that care, but we're still gathering that data to be able to understand whether there's any improvements we need to add to our improvement plan. We would expect our thematic reviews to be completed by the end of January, and then we'll start putting some, if needed, some robust quality improvement around anything that's identified throughout them thematic reviews.
Thank you. So we'd hear about that at Quality Committee in February, I think.
Yes, yeah.
Thank you. Aaron?
My question's been asked, Chair.
Brilliant. Thank you very much. Okay, Heather, I'll just check with colleagues. No questions on that one. Should we move to 1822?
Yes, thank you, Chair. So that paper is, just let me check the revised agenda just to make sure I'm doing the right one.
It's a 6-monthly continuity of care report.
Yeah. So this report is to give board an update on our continuity of carer teams. Just to remind board, we had a NHS England letter asking us to remove all targets for continuity of carer in terms of percentages and the deadline. However, it didn't remove our requirement to report to board updating. So it's a short report just to inform board where we are in terms of our continuity carer provision. So at the moment, we've got no continuity of carer teams running. As the ask was from NHS England was to focus on putting the building blocks in place that are required for continuity of carer, which is around recruitment. And currently we're looking at all our public health demographic and data to be able to inform where we would put our continuity of carer teams when we are in a position to implement them. That's all I wanted to say about that particular paper, unless there's any questions.
Just ask Heather, it says to be noted, but it's got for assurance. So is there any assurance issues you want to bring to the board's attention from that?
No, thank you, Chair. It's just to note.
Okay, thank you. Liz?
Thanks. Thanks, Heather. And noting all the things that you said about that this has been taken away nationally, the targets. Do we have any ideas though of when we'd like to be able to offer that service? Because obviously, if you know, for the women that it's going to be aimed at, those that are living in areas of highest deprivation, poverty, it will be critical and will make life can make life-changing opportunities for the children born in those areas, can't it? If we can intervene and help very early in pregnancy and see through.
Yeah. I think the challenge we will have in maternity services, and this is nationally, not just locally, is the steer from NHS England was not to do any continuity of care until you was up to establishment. So that's going to be quite difficult to do that quickly. So although we're really focused on being able to do it as soon as possible, that will be very much dependent on terms of our recruitment trajectories. And I think, to be honest as well, what we're also waiting for nationally is the new maternity and newborn plan that's due to come out at the beginning of the year, because I think that might give us some steer on what to prioritise first.
Okay, thanks, Heather.
Great, thank you. Colleagues were asked to note this paper. Okay, thanks, Heather. The next one you've got is 1823, Maternity Incentive Scheme Year 4 report.
Yeah, thank you, Chair. So this is an update for board in terms of our CNST position for Year 4. We are still awaiting feedback from NHS resolution on Year 1 still. To inform the board that we are projected to achieve 7 out of 10, if not 8 out of 10. The 2 safety standards that currently are non-compliant are transitional care and workforce. And the reason that they will not be able to be compliant by the evidence submission date is because of historical issues of not reporting certain items that are required. So there's no manoeuvrability in being able to achieve them. But I think just to share with board that there's real good progress evident. So for CNST Year 3, we were only actually compliant for 3 out of 10. So there's quite a significant improvement in terms of being compliant towards all 10 safety steps. The evidence bundle for CNST will be presented to board in January, ready for the submission date in February. Thank you.
Heather, it's Aaron. Just those 2 areas of non-compliance where the rationale for non-compliance is because we haven't been doing it long enough to satisfy the ask. Are we clear then that the actions are now in place that, you know, if there's a sustainability test in the future for both the transitional care and workforce metrics, we're satisfying the ask now?
For safety standard 10 for the 5, sorry, for the midwifery workforce, yes. Currently for transitional care, no, because it'll require a business case because the neonatal staffing at night is non-compliant. So until that bit's been done, we won't be compliant with that until it's in place.
Okay, so one of it's around historic reporting and one needs a change enacted. Can I just ask then, in terms of timescales for that business case, when are we expecting a proposal to come forward?
So Nicola, as the Associate Director, was doing a paper following the neonatal workforce review. That was last month, so I would expect us to have that by the end of January.
Okay, thank you. Can we just link in with Maria Caparelli on the Trust Management Group agenda just to make sure we're set up ready to receive the case when it's ready?
Yes.
Thank you.
Of course.
Just before I bring you in, Heather, just to add an additional question from the Chief Exec there. Are our women, parents, babies, are they safe?
Oh, yeah. Yeah, so the transitional care standard is just about the type of workforce model we have out of hours. It's slightly different between Barrow and Lancaster, so that just needs aligning. So once that's done, the service is there. It's just being delivered by midwives instead of nurses. So that just needs transitioning over. The midwifery workforce is more about the metrics that we report and respond to. That's been put in place. So they're already there. We just don't have the data for the required 6-month period that CNST require. So there's no issues in terms of safety from my perspective.
Thank you.
Thanks.
You and then Karen.
Yeah, I just think I want to highlight the amount of work that's been undertaken to get us to this position. I mean, we may feel it's unfortunate we haven't got all 10, but clearly 2 of the issues are a little bit more structural in terms of how we can achieve them because of going backwards as well as going forwards. And Heather's highlighted the issue about neonatal staffing, and we obviously looked at this indeed in some detail, but we will be looking in a lot in more detail next month at Quality Committee. The submission will come to us at the committee first before it comes here.
Thank you.
So
I'm taking that, Hugh, as an additional assurance point if that's okay. Okay, Karen.
Thank you. And Heather, it's really clear that there's been a huge amount of really sustained and thorough work to get us to a much improved position on CNST. And most of that's been the second half of this year. So it's been very focused on and particularly related to you and colleagues. And really, I'd value assurance around how far we're making gathering and collecting this data and making sure that we've got the actions in place, how that's becoming embedded as business as usual, so that we don't find ourselves with this incredible focus towards the end of next year.
Yeah, I think one of the challenges with CNST is it's very much building blocks. Every year builds on the last year and the last year. So if you're really if you're non-compliant for some of the earlier years, it makes year 3, year 4 really difficult. So for me, we've got a really, really good foundation now. We know what the requirements are and we can just build on it and improve, and people understand what the ask is. I think before people didn't really understand the specifics of the date. It's really, really specific, and you've got to be really focused and make sure that you tick every single little box. And we've now got assurance processes to make sure that that's done on a regular basis, so it's not a last minute review of evidence, it's continuous throughout the year, and that the whole team's involved in that process, and it's not just 1 or 2 of us doing it before the submission. So it's very much an MDT approach, but it's spread out across the year. So I'm looking forward to next year, because we'll have a lot longer to be able to achieve the whole 10 standards.
Thanks, Heather.
Thanks, Heather.
Thanks, Chair. Heather, I know there's been significant improvements around the number of midwives that we've got in post, and that still remains as probably our key challenge at the heart of the issues that we're looking at today. And in part 1 of the reports, there's reference to a draft workforce plan. And I'm just seeking assurances that that's going to be fit for purpose, robust, and will be operating as well within our local health economy, you know, within the ICB.
Yeah.
So it is sustainable. And I'm just wondering, is that something that we could have a look at the People Committee? Thank you.
Thank you. So there was a draft workforce plan done a few months ago, but what became apparent when I did the tabletop exercises, there was some slight anomalies within the birth rate plus calculations. So currently we're just doing a full establishment review with support from the maternity safety programme, but also the regional team, to ensure that our establishments are absolutely as they need to be, which then will feed into the workforce plan. So the reason the workforce plan hasn't come out yet is I really need to make sure that the establishment's as it needs to be now before I add the workforce plan in, because it may change some of our vacancy rates to better.
So could I just ask, Heather, when are we likely to see that? When are we likely to receive that, and where would it go to? Thank you.
So the establishment review obviously has got maternity support programme involvement and the regional team, so we're somewhat reliant on their availability. We're hoping they're coming at the beginning of January, so I would hope that the establishment review will be finished by the end of January, and then we can start taking it to People Committee and QAC probably in February, but that will be dependent on their availability and any other sort of system events that sometimes knock us off track.
So Heather, we've got a process for it, but
Yeah.
a rough approximate dateline, but it will get to the People's Committee, we think February and possibly March.
Yes, thank you.
Thank you.
Thank you.
Thanks, Adrian. There's no further questions. I want to, I know we've got 2 more to do with you, Heather, so I'm just asking people to concentrate really, because I want to bring Scott in before Scott goes at 10. So I want to move us to another agenda item before Scott leaves the meeting. So we've got 1824, the Ockenden review update.
Yeah.
What would you like to bring to our attention?
Thank you, Chair. So this is just an update report for board. This is against obviously the initial Ockenden 7 immediate actions. We had an assurance visit in July, you'll recall, where we were rated as amber across all domains. That's in Appendix 1. We put a robust action plan in place, and you'll see our compliance as of December in Appendix 3. So there's evidence of progress. I expect full compliance by February. We are due a reassessment by the regional team and a visit. So hopefully the actions that are outstanding will be completed before that visit.
Thank you.
Thank you, Chair.
To an update on progress, we know there's a visit coming, and then hopefully the deadline of February will be fully compliant. I know you'll bring that back to the board, Heather, so.
Yes.
Questions from colleagues. And the NHS resolution thematic review.
Yes, thank you, Chair. So this is just an update on the progress against the action plan following our thematic review from NHS England into our early notification cases. And again, it's just to provide an update and assurance to board that we are making progress against that action plan.
Great, thank you. Which, just ask quickly, which subcommittee will oversee that? Where will it go? Quality, great.
Yeah.
Don't want to repeat some of the assurance work that the subcommittees are engaged in, so thank you for that. Any questions on that one? No, great. Heather, thank you. That's a large number of agenda items, so all related to assurance. Well done. Please have a really good Christmas. Pass our best wishes on to colleagues. Thank you.
Will do. Thank you, Chair.
See you at the next board. Okay, colleagues, the next item we've got is actually 183 Recovery Support Programme, but as Scott is leaving us at 10, with your permission, I'd like to go to 1841 and ask Scott to bring any items there, particularly around obviously operational, that he wants to bring to our attention for assurance purposes before you leave us at 10, Scott. So over to you.
Thank you. Thank you, Chair. I know Suzanne's going to coordinate the broader IPR item, but thank you for indulging the time. So the in the usual chunks of urgent care, cancer, diagnostics, elective and stroke, you'll see in the pack urgent care, we continue to be in special cause variation up to October. What I would say is November data, we are our best month in the last 18 months for urgent care. Which is encouraging. That's in the last 2 weeks started to turn back to the data you see in the pack, and the pressures are well rehearsed, not only in our trust but nationally. By exception, and you'll hear it in the RSP report, in terms of our plans to address that, we'll deploy the winter plan as has been to the board previously in Anger on the 28th of December, so additional capacity, and winter alternatives will kick in then. And the urgent treatment centre, which was part of that, is slightly delayed due to supply chain issues, but we have a mitigation for that. And it is worth noting, as always at this point, that the patients not meeting criteria to reside remains stubbornly high at 149 today, which is around 27% of our bed base. In the cancer space, again, we are in common cause variation. The thing I would pull out to the board is our 2-week wait performance, while at 91% against a target of 93% is top decile, not only in the region but across the country. So we are seeing those very important early cancer patients timeously, always more we could and should be doing. We had the inaugural cancer board last month, chaired by the Chief Medical Officer, which will be our locus and governance point for that feeds into the quality committee. In diagnostics, a special cause variation and cause for concern over the last 2 months, but I'd assure the board we've got a locked-in trajectory that is progressing over the last 2 months, and we will deliver back to the 5% target in Q4 for 6 of the modalities and Q1 of next year in the other 2 modalities. That's well ahead of our peer trusts in the pack. In the elective space, I'd reassure the board that the on page 178, the 4 patients stated to have reached 104 weeks are not, that's a patient choice issue, so our reported position is 4, but our fundamental position is 0, other than for patient choice, which remains positive. As I've said to the board previously, you will see the November and December elective data deteriorate somewhat because of the lag of reporting, because that's when the impact of the BMA rate card was felt. So you'll see that feature in November and December's data. The paper to the quality committee on patients past IRD remains scheduled for January. And I would flag here, although in draft, and I wouldn't normally bring a draft audit finding to board, it's worth saying I do take a great confidence from what I've seen in the draft report from our external auditors, that we've had a level of significant assurance around our waiting list health. That's unusual in the NHS. So we have a very expert team who've invested 5 to 7 years of very hard work in our waiting list governance and processes. And so as I expect that becomes the final audit report finding, then a level of significant assurance, the highest level, is very, very reassuring, and we should take some confidence in that. Finally, in stroke, the Q2 data tell us that the SNAP score at Furness General Hospital was an A. That's outstanding, and I'm sure the board would want to commend the teams that have delivered that, as ever. SNAP is one part of our stroke measurement, and there are many more, but to achieve that A under the pressure that team are under is outstanding. And the score at RLI remained a C, which means for 4 of the last 5 quarters, that's remained a C, again positive. Our stroke improvement plan, we expect to improve the score within the C domain over the next quarter. So happy to take any questions, Chair.
Thanks, Scott. I'm conscious Susanne's going to do a breakdown of these, but any questions to Scott?
It's not a question, Chair. It's highlighting the continued risk that we face through the not meeting criteria to reside numbers. 27% of the bed base is not okay. And you'll have heard from Scott the evidence around urgent care and elective recovery and diagnostic improvement plans, which puts us in a good position against our peers regionally and nationally. That is despite the issues that are created through having that amount of our beds not available for good quality and effective patient flow through the organisation. The board will be aware and has had assurance previously around our winter preparations in that space with the external contract for additional domiciliary packages, which we'll be mobilising this week and through the next few weeks, as Scott's just articulated as part of the winter plan. We are in dialogue with our place-based directors and ICS colleagues about what more could be done in the social care and domiciliary care space. That conversation happened yesterday. We're asking for updates today and tomorrow as we head into the 4-day bank holiday weekend. And I know there is a conversation within the ICS strategically about a long-term plan for the market resilience and improvement to enable those numbers to reduce. So we'll be able to provide an update for board as that work progresses in the region through the operational performance updates as it occurs.
Scott, just to add again on what Aaron's just said, the 147 people, these are all 147 individuals who are here in our hospital who shouldn't really be here. I'm not saying they're well, but they should. Is there any chance that we could have a space in January on a patient story so that we can get an insight into exactly what these individuals are experiencing? Because I imagine the frustration level from carers, families, and the individuals who are here must be high. It would just give us an added insight if we could have a patient story about how did they come in, what is happening, with individuals when they're in that criteria to reside? What is the criteria being used in certain circumstances, and how do they then leave the hospital? Where do they go, and how safe is all that?
Chair, if I may, I'll ask Bridget to look at it. It takes quite a while to build a patient story and get a patient to come into consciousness at Christmas period. So I don't know if we'd have that prepared for the January board, but I'll ask Bridget to work with the patient's experience team to get something like that in place as quickly as we can.
Brilliant. On that note then, Bridget, would you mind as well if one of the NEDs, I'm volunteering one of the NEDs here, or myself, if you just give us a couple of our patients who are in that situation, and then we could get an update on what's happening with them, where they're going. Just 2 patients that we can follow through and get an update on them. I'm sure the NEDs would be interested in that. Colleagues,
yes,
you okay with that? Yeah,
Definitely.
Bridget, if you just take 2 at random, that'll be even fairer, and just say, right, we'll follow these 2 patients through. Just keep us updated, because I'm conscious that, you know, I'm not saying in this trust, but I think in the NHS, we're beginning to normalise these, you know, the criteria to reside. We're beginning to normalise that individuals are staying in hospital more and more. And I worry about that, because they are individuals and they are under our care. And I get everything you've said, but we really need to understand what it's like from their perspective to try and improve the service.
Yeah, of course.
Thank you. Thanks, Scott. Any questions for Scott outside of the subcommittee work? Scott, I'm going to ask you to pass the floor over to Suzanne then. I know you've got to go at 10. Can I just ask you or the chief exec, which executive then will be responsible to take us through or to end with Suzanne's report if you're gone?
So Suzanne will hand off to the executives for their relative sections and do preliminary check.
So you're coordinating?
Yes.
That's great. Scott, I know you've got to go to the update meeting at 10. And we'll probably see you beforehand, but thank you and stay well.
Thanks, Chair.
Scott.
Okay, thank you, Chair. So in presenting the performance report, just remind board members that the timings of this meeting mean that it's not the full integrated performance report, and the composite report for October will be shared with members in early January, so that'll be shared through. Just to remind, obviously the IPR is still being developed. We've now got board level metrics at a care group level, and we're looking at those through the performance reviews, and focusing now on care group specific metrics, along with obviously the development of the committee level IPRs, both of which will be ready for that 23-24 reporting cycle. So those will be ready in the April position. So I'll take it that the report is as read. The cover report highlights a number of key issues across all of the portfolios. I think as Scott had already mentioned, we have put some reference to ourselves against benchmark national and regional position, which I think colleagues had asked for previously. So I think that helps in the narrative of how we are performing. But I'll refer to my colleagues, because obviously the cover report highlights the key issues, but I refer to colleagues to provide that high level briefing and answer any questions the board may have. So Bridget, I wonder if I can pass over to you for safety and quality.
Yeah, of course. Thank you. Apologies, I've got a little bit of a cold, so hopefully you can hear me clearly. So I won't overstep the purposes of the quality committee. We've already got the AAA in there, but from the chief nurse's point of view, there's some things that I would just like to draw out particularly. So in terms of our work around patient safety, and it leans into the work around our new governance framework, I'm pleased to see in terms of, and want to just assure the board around our reporting for both moderate harms, which you can see is actually a steady state and reducing, but actually in terms of our level and type of investigation for learning, which is the STICE measure, actually they have seen an increase since we changed our process, which was in July, August, and the purposes of that in terms of giving confidence is around the type of learning and the type of report that we're doing. So that's just demonstrating a clear change in our process. So I think that's good. In terms of the work around falls, you'll know that I reflected last month that we had a fundamental care practitioner that had commenced. There's nothing specifically at board level in terms of statistically significant, but in terms of the other subsets of data we are seeing progress. So I'm confident that the changes will have impact over time. In terms of the work on pressure ulcers, you'll see the reflection within the Quality Assurance Committee, and we're expecting a deep dive under the fundamentals of care. We're not demonstrating the progress we would expect despite the efforts that we're putting in. However, what I would say is that Suzanne's alluded to the fact that we've now got data at micro level, at ward level, etc. I just remind the board that the stretch target I've put in per 1,000 bed days for the organisation is 1.5, and you can see that we're currently at 1.71, and I think that's important. Next month I'll be able to report the breakdown. So actually, in terms of surgery as an example, they are reporting well below that, so they're performing better than, and we can see that because we've got the new IPRs, whereas within medicine, you'll see over time that that's a little bit more difficult. And what that means is, as an organisation, we can really know where to focus in terms of getting the improvement, and I think that will pay dividends over time. I was asked within Quality Committee when we expect to see the improvements. I'm going to hold that until we review the deep dive work in January. Just a nod in terms of the infection prevention and control. So we are above trajectory for Clostridium difficile, and whilst that is a national trend, I've asked for a number of things as the DIPSI to be done in terms of reviewing all of our processes in the organisation. So we'll report that through the Quality Committee. And the last thing just to mention was the mixed sex breaches. So you'll notice that we have had a slight increase in terms of our reporting. And I just wanted to assure the board or advise the board that that's related to flow within the organisation. It's specifically to do with critical care, where patients are not able to step down, as we would describe, within 4 hours out of the critical care environment, and hence why we have an increase. So that's what that's related to. And just the final thing for board, you'll note that a couple of months ago, and I think it's on the forward plan, that we're expecting the patient experience strategy to come through in the early months of next year. And it's really important, Chair, I think, because the Friends and Family Test gives us some measures in terms of patient experience, but actually reflecting on the question you've asked around, for example, patients not meeting criteria to reside, other schemes that we've put in for winter. What I've asked for is in the patient strategy is how we then reflect that back in a qualitative way to board, and that we get sort of a richness at board level. And I think that's really important given the question you've asked around patients who are not meeting criteria to reside, and I'm expecting the strategy will enable the board to be more assured in a qualitative way about patient experience. So it was just a final comment. Thank you.
Thank you. Just a quick one from me for I recognise Quality will look at this. Bridget, the mixed sex thing you said and the critical care and the 4 hours stop down, has that now stopped or is that ongoing? And if it will. When do you expect to see a reduction?
So I think it's a real challenge, and it is for some organisations. So in terms of advising the board, I think that it's something that we'll monitor. We've got a lot of things happening currently. We mentioned Aaron, the Chief Executive, mentioned about things that we might do differently. So I think there's opportunity through this period to see what else we can do in terms of the focus on flow. But it is going to be difficult through this period, and I think that was similar to last year.
And I know Quality will oversee it, but I'll be good with you. But Hugh,
yeah, I mean, Bridget's outlined in quite a lot of detail most of the key issues that we raised on Monday when we looked at this. Just want to highlight a couple of other areas, which is one's around mortality. The fractured neck of femur working programme appears. We don't want to spuddle here. Using the terminology we've been given by our colleagues, data colleagues, but the data is starting to show a drop in the mortality measures around fractured neck of femur, and we hope that the next set of data that we'll see in January, and Google will confirm that. So that's some green shoots. So I think it's not just one measure, it's actually through the last 6 years. As we know, it's a 12-month rolling set of data. The other area within that, which I think we just need to be aware of, congestive heart failure was flagging as potentially a red area for us, and the medicine care group is doing some urgent work to just assure us whether that's something we should be concerned about. The numbers are quite small, and that's part of the problem. with some of the mortality data. It's not with fractured neck and femur, but it is actually with things like some of the there's peripheral there's one about vascular and atherosclerotic disease, and there's congestive heart failure, and it may be that the numbers vary, but we will be able to report next month whether those are true issues or not. And the other thing I'd like to highlight is that VTE assessments do seem to be still quite persistently at around the so I think it's about the 85% mark rather than our target in the mid-90s. And again, some significant work's being done with the appointment of various for champions, and Amita Joshi really has got the bit between the teeth on that. We're having a further detailed report at the Quality Committee in February on that, so that just so that the board is aware that we have got that under close surveillance.
Thank you. Sarah?
Thank you. I just wanted to mention the MUST data, because we're not seeing that at the moment in the IPR. We see it board, and actually we didn't see it at Quality Committee on Monday either, but I understand it's being monitored. And Bridget, you just updated us on that, I think, too. So we're expecting an update, because I'm conscious it's flagged as part of the RSP programme. So for me, it's really important we can seek assurance around what the action plan is and when we can start to see improvement.
Do you want it in the Quality Committee?
So Bridget confirmed to us on Monday we should see that coming to Quality in January. But I think that was important to talk about because it's flagged as part of the RSP.
Bridget, anything you want to respond there to Sarah's point?
Yeah, so just in terms of the news, so I've mapped every quality measure that's either in the RSP programme or out width of anywhere else, so that we've got it either in the governance function or in the new IPR. So it's a feature in the new IPR and also the ward dashboard. So there's just a time lag, so between January and March, but it's coming through our reporting anyway through fundamental care. So we've got an interim arrangement, and then it'll appear at the end of March in the new IPR.
You're right with that, Sarah?
Yeah.
Just before you bring in Liz, I'd just remind everybody, try and avoid acronyms, because this is a public board. So members of the public may be watching this. So if there is any acronyms, could you just explain the context or at least what it means?
Yeah, apologies, Chair.
Thanks, Mike. Thanks, Bridget. Can I just, and apologies if this has been discussed at Quality Committee, because I don't sit there, but I think it's something that needs airing at board. The increase in pressure ulcers and the severity of pressure ulcers, is there any linkage between patients not meeting the criteria to reside and spending longer in hospital, but also coming into hospital in a poorer state than they would have done in previous years because of you know, sort of problems with heating and COVID and general, you know, people getting poorlier?
Thank you, Chair. So certainly in terms of our lines of inquiry, so deterioration of pressure ulcer, yes, in terms of what we're seeing in terms of those patients who are requiring a pressure ulcer, certainly within 72 hours of admission. So we're expecting as part of the deep dive work to bring that back in January into the Quality Committee. But yes.
Thanks. And so leading on from that, when do you think we're going to have any sort of joined up thoughts and processes from the ICS on a solution across the ICS? Yeah, probably, because I think Bridget is probably closer to that.
So I don't know is the honest answer. There hasn't been a timeline that the ICS has put forward, but I know the conversations have started now. I think what I said before is once we've got an update on the timescales and the process for locking that in, we'll bring it back to board in the new year. In the meantime, what we're doing locally is the action I discussed earlier with place-based directors and the current ICS lead and what we can do over the winter period. I think the strategy regionally about strengthening the residential care, domiciliary care market, I think that feels more like a 6 to 12 month piece of work, because I think there's some structural changes that are needed. In the meantime, we need to make sure we're doing what we can with what we've got. So we'll make sure we brief the board as that progresses.
Thanks.
Adrian?
Thank you. It's just that it's that point, Aaron, actually, that I wanted to pick up on. I didn't want to detain Scott earlier on, but if we're going to have a look at the criteria to reside numbers and where they're coming from, in the early reports that you provided today from Kevin Lavery, there was a brilliant overview of the use of additional residential care, virtual wards, and it would be really helpful for the board in its 12-month programme just to be able to be updated on that and the business case for how we might implement that locally to support our response to this absolutely fundamental issue that we've got. So I just appreciate if we could start that journey with the patient story, you know, so that we're bringing the board up to speed and we're understanding the business case and how we might enact that within our local health and care economy across Morecambe Bay.
Can I just ask what business case you're referring to?
It would be about, because I know that LTH and I know that East Lancs have actually invested in virtual wards and residential care facilities, haven't they, separately? So they've obviously understood and considered a business case to invest in that. So
have we. So we've done that as part of the winter plan updates to board. So we are performing as good, if not a bit better than others on the virtual ward expansion. The residential care offer was a very specific national funding, prioritised, targeted piece. It wasn't business case driven, but we're considering as part of the model whether we might consider at place level moving into the market, if that's the right phrase to use. So it's all wrapped up in the ICS-led piece of work. It wouldn't be separate from UHMBT, but the virtual ward expansion and delivery we've been doing. I haven't got the figures to hand, but we can provide them to the board as to its utilisation.
So we're doing that at the same scale?
Yes.
If not more?
Yes.
I think that's probably what Aidan's alluding to. If we could just have an update.
Yeah, absolutely. Yes, we can.
We'll put it in the board agenda, Aidan.
Thank you.
We'll sort of spend more time on the criteria to decide.
It just feels, Chair, that we're going to have to do quite a fundamental shift in how we're actually operating, doesn't it? And I do feel that needs more preparation over the next 12 months so that we're on a front.
Just attach it to the same action we just agreed with, Liz, so we don't do.
Thank you. Richard, thank you. Oh, Suzanne.
Sorry, Chair, just in response to that as well, I think some of those patient stories are really useful. I think the other ones to caveat it with is a story where we're turning people around at the front door. So there was those sort of schemes that were put in place now around frailty into ED, turning around on home first. If that patient, so that was a really successful story, and if that patient had been admitted, it would probably, that gentleman would have ended up being one of the not meeting criteria to reside. So it'd be really good to look at them in that dimension of the two stories and how actually investment in some of that other thing rather than residential makes the better outcomes to keep them at home.
I agree, and if I may, the Falls team as well.
Yeah.
Really good stuff there, and it's really understanding the scale and the impact of that, isn't it?
I'm just wondering, Chair, whether rather than separate papers or updates, whether there's a session with the board, maybe in workshop mode, about post-improvement review of the kinds of pieces of work we've done, either the winter preparations or urgent care flow improvements, just to do a bit of an expo for now with the board so we can update. I think it might also lean into the points Adrian and Liz have been making on the residential auxiliary care piece.
If I may, sorry to extend it again, but it is about the return on investment. So if we do that, what's the impact on our numbers? Is it more cost effective to invest there rather than more events? That's what I really want to understand.
We'll have a session. We'll have a board update session.
Sorry to labour it, but can we link this as well to one of the aims of the ICS and also of us is to reduce forget what the word is, the difference in outcomes for different people in locations. And I don't think equity,
it is addressing inequality,
yes. And equity and differences and lifespans and such like, and it's quite obvious, isn't it, that if you have money and you've got a frail elderly relative, if you can access care personally and pay for it, you can get that family member home.
We'll take Aaron's proposal to the board. That we'll have a session on the board on this, and then if people have got any questions or specific issues they want to cover in that session, Suzanne, do you mind playing the repository for that? We all send it through to you. Yeah. So we've got any questions? So that just email Sam. We'll have that. Then we'll make sure we'll cover it in the session rather than in the session. Catch everyone by surprise. Suzanne, I'm conscious of time.
Yeah, thanks, Chair. So I won't hang about. I'll hand over to Ray to highlight the areas in the people and OD section. Thanks.
Yeah, thanks. Thank you, Chair, and thanks, Board. So the one thing that I'd like to highlight that's in the report and has now been completed is the piece that we've said around the leadership, which links directly to our RSP exit criteria. We have successfully met the target that we set ourselves. As part of the work, we have actually identified an additional 400 colleagues that would benefit from that focus one. That training will be delivered during January in additional sessions. So as assurance to the board, we have met that target. We have actually exceeded it, and we are going to deliver additional training. Focus 2 will then begin in February. So as part of that programme, we will start to see the further development on that. And also the Triumphant Leadership Programmes are now up and running and being very highly commended for what they're doing. So that will obviously help us towards our well-led domain improvements as we go forward. That programme is obviously still in its development, and as part of that, we are looking at appraisals and how we can drive appraisal compliance. If you look into the chart in a moment, there is no assurance that we will meet the current target that the board have. Part of that has been done around looking at what is being asked of colleagues and how they are being asked to report, and the importance of well-being in that, and how we actually really get engagement with our colleagues. So there is a set of stakeholder workshops that are currently being run to look at appraisal in detail, and there will be a proposal that will come through People Committee on what we're doing with that. Obviously linked is core skills framework compliance and mandatory training. There is work going across the ICS, so the integrated care system, to ensure that what we are doing is meaningful and is adding value to the organisation and not detracting from colleagues' vital time. A prime example is a junior doctor has 85 mandatory pieces of training that they must do every single year. Some of that is actually a duplication of effort. So we are looking at how we reduce that and standardise that and make sure that across the ICS, we are delivering that. That said, we have performance of our core skills framework in the upper quartile nationally. So we are performing exceptionally well, even though currently we are not meeting the trust target of 95% for core skills framework. What I will highlight is that outstanding organisations don't set targets that high, and they are not meeting it. So the fact that we are in nearly 94% shows just how well we are performing as an organisation, even in the most difficult of circumstances that we are facing right now. And the reason that we are not, and we were at 97%, is that a number of the extensions that were granted for COVID have all fallen off in the last 8 weeks, which is what has seen that drop below our target. So from that perspective, we're really focusing on all of that. The only other thing that I'd like to highlight to the board is absence. Absence, unfortunately, is increasing. We do expect that during winter, and it is linked partially to vaccination rates. And again, this was discussed yesterday on our IMT call. Although we lead the ICS in vaccination rates, they are still significantly below where we would like them to be. Currently for flu, we're at 47%. At this time of year, we'd normally be at 90%. There has been a huge piece of work undertaken by Occupational Health to understand this, and that review will continue, and that will report into the March People Committee to show what its findings are. We've got lots of evidence around why that's happened, and one of the biggest reasons being quoted is VCOD. Yeah, sorry, Aaron. I will wrap up there, and I'm happy to take any questions.
Well, we recognise many of the points you raised going through the People's Committee. So any assurance questions? I would just ask through the People's Committee, I'll bring you in a second and just make a quick request through the People's Committee that we look at that 95% measurement, because as we've had with our data training, what's the point of having a measure that we quite can't, you know, so just compare it with model hospitals or grid. We want to be a SOC 2 within 2 years. Yeah. So there might be a merit in that, but it's pointless having a target that is just there for tokenism. So you have a look at that? And be
Absolutely. So we'll come back and report on that following our March meeting, if you're happy with that.
Thank you. Karen?
Thank you, Chair, and thank you, Ray. My question is really specifically related to the leadership work, and recognising that that's going very well. My example is really from maternity, and we're now really seeing, although there's been a great deal of improvement, issues now like succession planning, leadership development, embedding the continual improvement culture, particularly around some of the specific maternity challenges, are now beginning to exercise us in terms of medium and long-term sustaining of the improvement. And my question is how can we be assured that the OD and leadership offer will become increasingly tailored to the identified needs of teams and services and care groups, recognising the more generic programme is really now taking place. It's how we tailor that more specifically.
Karen, that's picked up in focuses 3, 4 and 5. So as part of the programme, it is specific to services. Sorry, it's all in one sentence.
Okay. And the People Committee will look into that as well, Karen. So we'll come back and provide assurance on that specific point as well.
Excellent. Thank you.
Thank you. Okay.
Yeah, so thanks, Chair. So I'll immediately pass to Helen just to provide an overview of finance.
8 priority points, please.
The report references the end of October position where we had an adverse position to plan of 2.4 million. We undertook a peer review within the ICB on the 7th of November, which was quite a rigorous process, looking at our forecast position, which at that point in time stood at 17.5 million. We're obviously 2 months further on from that date, and we've reported in month 8 an improved forecast position of 13.6 million. We are tomorrow required to submit to the ICB our kind of final position, where I'm hoping that that's going to be a further improvement. So there's just a little bit more work to do during the day and tomorrow. We'll obviously report that back to the board.
Good, lovely, succinct. Thank you. I think realistically we just have to accept, and this is for the execs really rather than the board, that the ICB will push back. Will expect us to make even more savings, I think probably in this year as well, forecast, but we'll be ready for that.
I think that's an important point, Chair. I think it's also important for the board to be aware that given the stretch this year and the circumstances of the financial planning framework, much of what we are doing is technical and utilising lots of flexibility we have in the balance sheet. Having said that, we have the highest proportion of recurrent savings in our plans in the region, which is encouraging because that signals the intent that the board has with last year's planning for the Strategic Financial Improvement Programme. I think where we'll get to in Q4 is some space for the board to reconsider its SFIP approach and what next year and the year after starts to look like with that transformational change agenda that we've been sponsoring. We need to move out of the perennial in-year rescue package to get to a position. I'm really confident with the work we're doing across the finance community and actually ops and clinical community now at the ICS level that step change on clinical strategy and workforce strategy is starting to bear some platforms for us to build off. So I think Q4 will be a signal for the board to engage in that agenda. Chair.
And we're going to have to, because it's part of our drive towards soft 2. We're going to have that. We can't have the year recurrent all the time. Okay, thank you. Helen? Suzanne, is that it?
That's fine. Thank you very much.
Thank you. I'm conscious this morning's board is around assurance because I'm conscious our operation colleagues have to go back out there. So quick one then. We've got back to item 183, recovery support programme, our UHMB improvement plan. Welcome, Sarah. You've been sitting there very patiently. I think you heard me say, bring us to the main assurance points, please.
Yep, so 2 of the 3 issues have already been covered by my colleagues. The 3rd issue to pick up is around the number of SGRs that we are doing, and the medical director team have a clear plan for recovery of that position, and they have a trajectory to improve that. So that feels confident that we will deliver that, but we will continue to monitor our position because we have deteriorated in the percentage of our deaths that we are reviewing in the SGR process. If the chair, you would allow me to just touch on, we had a further gateway review meeting with our regional colleagues at the end of last week. And essentially the key points to come out of that were that they are meeting with our ICB colleagues around what the single agenda item SIB would look like, which is still timetabled for April 2023. And they are working with our ICB colleagues to understand how our ICB colleagues will balance oversight and support to us, because it's going to be a difficult role for them. The same regional colleagues will be meeting with the National LHSE Directive to discuss the anticipated format of that support moving forward as we look to transition out of soft 4. And the other thing that the regional team are picking up with our ICB colleagues is around the support we will require as we look to transition from soft 3 into soft 2, as you've articulated previously, Chair. Just to confirm that a formal NHS England review is not scheduled for January, and that the regional team are currently exploring dates in April with the national team for any formal meetings with the national NHSE directives, and that we will continue to brief moving forward on our plan for ensuring we meet those key stop-go elements for the RSP exit criteria, because Aaron has asked us to look at what we need to do given the increasing operational pressures within the organisation.
Okay, thank you. That's an update. Aaron?
Just for the board's awareness, I've been working with Suzanne and the executive team to construct our 23-24 annual plan with the theme of the soft 3 to soft 2 improvement trajectory. So whilst we are looking at what support we might need and whether it's a recovery support or an improvement board type approach, the construct of our plan will seek to build off the improvements we've worked through as part of the exit criteria and clearly show a matrix of alignment from soft 3 to soft 2 and what work will be progressing through 23-24 to achieve that objective, Chair.
Thank you. We're taking this as an update report then, Sarah, because we'll get clarification on date lines in the January report. So thank you for that.
Thanks, sir.
Sarah, thank you. We note the report, colleagues. Okay, we'll move on to item 1842, minutes of the 3A reports. Then just ask colleagues just to bring to the board's attention any assurance issues, because I know the subcommittees are doing a lot of triangulation and deep dives. Adrian, anything people committee to bring to our attention?
Just that our new director, Alison, will be starting in January. Looks like a fantastic appointment. We've had a great discussion about the forward planning, particularly around workforce. And the only other issue that Ray hasn't mentioned is about the psychological support from colleagues. There's been a spike in demand, and it's just about meeting and servicing that need appropriately.
Yeah, brilliant.
Thank you.
Thank you. Karen, anything from finance and performance?
Just one item, Chair, in addition to what we've already heard from Scott, Helen and Suzanne, and that was that the committee this week considered and approved the business case for the single pathology service digital histopathology service that was focused on really improving resilience, efficiency and effectiveness, and it was presented on behalf of the Lancashire and South Cumbria Pathology Service. It was really thoroughly scrutinised, and with consideration to a number of caveats that were related to benefits realisation, and being very clear about the commitment to redistribution of funds to providers being secured with appropriate escalations in place should that be compromised. And we also wanted to be really clear that any new NHSE processes were taken into account, and to be very proactive and transparent about the approval around forthcoming ICB controls. We approved the business case, and in light of that, that sits in the context of a collaborative approval, but we just wanted to advise the board that the maximum annual exposure in year was 280,000.
Okay, thank you. We note that. Okay, then Quality Committee, anything to add on what you've already said, Hugh?
Thank you, Chair. The report that you've got actually is a duplicate of the one that was received for last month, so I'm not quite sure how that, but that's so people don't get confused. There were no alerts to bring to the board from Monday's meeting, Chair.
Great, thank you. And if I can just ask Sakthi Karunanethi, is there anything, Sakthi, that you want to bring to the board's attention as our special advisor?
Thank you, Chairman. I've been very grateful for the papers in advance and been listening to this. There's a couple of things that really stand out for me from this morning, both of which are emerging themes that the board is trying to deal with in shaping its environment and the context. One is the market, and the third of patients in our hospitals not meeting the criteria to reside feels like a significant one that we may want to sort of deep dive into, having secured a timeline for addressing that. And the second one is related to mortality that Hugh mentioned. If you look at the trend lines, it looks as, although it's small numbers and there's all sorts of insights available to us, it looks like the trend has turned a corner from a declining trend to showing early signs of going upwards, which again, I would like to sort of highlight to watch out for. Thank you, Chair.
Thank you, Sakthi. And we note those points and they'll feed into our discussions either in the subs or the boards. Item 185, anything to bring our attention, Company Secretary?
Just very briefly, Mike, we pulled this through from the private board that we stood down, and a separate paper was circulated. The corporate meeting schedule has been aligned to the performance accountability framework timeline that's been developed this year, and therefore on that basis we are recommending that the board of directors meet in the first week of the month rather than the last Wednesday. Other than that, we would commend the schedule that's been circulated for agreement for next year.
Yeah, colleagues happy to support?
Yes.
Yeah, thank you. Item 186 is just for noting attendance monitoring. 187, schedule of business, subject to what Company Secretary said. No urgent business brought to our attention. I'll close this meeting then at 10:30. Just before I formally close it, just for the execs, there were a number of really good points made about areas of improvement in the trust. And Scott specifically said thanks should go, you know, to, for instance, SNAP, Stroke, and could we, through the Company Secretary and yourself, Suzanne, capture those points and send out a letter from the board to say thank you? I don't want to say congratulations yet. We'll do that when we're in soft 2, but to say thank you, it really is. We're getting every month now more and more reports, and we're triangulating them, showing signs of transformations. That's really good. So we just need to send a letter out from the board saying we've noted and we'd like to thank them. On that note, colleagues, I'll formally close the meeting. Have a wonderful festive season and thank you for attending this morning. Executive colleagues, I can't express our thanks to you enough. Just keep going. It's a really tough week this. We really appreciate what you're doing. I'm absolutely certain our patients do. So thank you. Merry Christmas, everyone.
Cheers, folks. Thank you.
Thanks a lot.
So take care.